So another topic that came up with one of our PTs today was the management of a patient with scoliosis. And this can be looked at in two different realms, meaning are they coming to PT for the treatment or management of scoliosis as their primary diagnosis, or are they coming in for something else? Maybe their hip, their shoulder, their neck, but they have a history and they are dealing with scoliosis, and that's influencing either their symptom or their movement profile. So I think you can look at this from a variety of different lenses. The questions that I'm about to pose are ones that are relevant regardless of the case. So things that I always like to know first off is what has been communicated to them already regarding their scoliosis. And some of this may be with regards to their age. Is this a younger individual who is still going through physical development and is not fully skeletally mature? Has it been expressed to them that they've kind of hit their peak as to what that scoliosis is and how far it will be exacerbated? Or is there the potential for it to become more significant and more severe? If it does have that potential, has it been communicated to them as to what are different benchmarks or landmarks? Are there any radiographic findings that they can utilize to quantify how little or how significant these changes are? And then what are those action items going to be? So I think answering that question always helps out, just so you can step back and get an idea of where do you really fit in with this picture, either from a leading the charge from a decision-making standpoint, or are you more on that intervention standpoint? And if you are intervening, what are we working with? Somebody who's in the beginning phases or the end phases of this, and are we in more of a management role, an educational role, or are we doing something to try to triage it in the moment as it is actively progressing? Second thing we need to appreciate is, how is this actually limiting them? Is it limiting them more from a pain and a comfort standpoint or from a functional standpoint? And if it's pain oriented, how much of this is something that we can readily influence? Is it soft tissue? Is it more actually due to the alignment and just the different stresses that their body is under due to the alignment? And then how is that alignment or that presentation influencing their movement profile? We obviously are going to be very, very limited in what we can do to actually regress or change the direction of this, but I think we can do things that in a weight room, in a strength conditioning standpoint, in a rehab environment, that we can minimize the flare-ups, the exacerbations, and just the overall apprehension of living and dealing with this, either in our day-to-day standpoint or in our athletic and more active endeavors. So I think that's an important thing to appreciate, and also to communicate to the patient that when you are prescribing exercise for them, is this under the understanding and the expectation that it's actually going to reverse something? Or is this under the expectation of doing this is going to help counteract some of the effects that you're feeling from the scoliosis? Maybe we're teaching you how to tap into some muscle groups that just from a length tension standpoint aren't at a very mechanically advantageous position to work. And we've got to work a little bit harder to teach your body how to recruit these muscles, how to feel these muscles and know what it feels like when you are utilizing them, and how we can carry that over into our daily tasks. We can also figure out which areas of the body are taking on more stress than what an individual without these scoliotic changes is going through. And if we can identify those areas that are going through a little bit more stress, what are some things that we can do in the moment or as part of a daily routine or just a regular routine to help them either get immediate symptom relief or just minimize the exacerbation of what they are feeling. And then I think a very important component to this is giving the patient an idea of not necessarily what's going to make them better, but what are some activities that are going to make this worse? And what are some activities that could really exacerbate things because you may be asking a muscle to do work and it's already in an extremely fatigued state, or maybe it's already in just a mechanically disadvantageous position to function. And if you're asking it to do above and beyond what it's already struggling to do, that's not going to end up well for the patient. So I think with scoliosis in general, we need to be mindful of what we're working with, what has been communicated to the patient, and what their expectations and our expectations are from a rehab standpoint. I think education plays a large role in this. And I think we need to look at both ends of the spectrum. What can we do to make this better? What are things that we need to avoid to do to make this worse or to exacerbate some of the issues that we're having? And then a lot of it comes down to either coping and management strategies as well. So if we know activities, what activities are going to irritate it, if we know what things from a leisure standpoint they're participating in that are going to exacerbate it, we need to help them find that balance of what's my threshold? How much can I tolerate? And if I go above and beyond that point, what are the things that I can do to help bring symptoms back down? But then from the other side, what are things that are just probably not going to change? And I think when we start allocating time and effort to our interventions, if we know what things we're going to have a limited ceiling with, either from a mobility standpoint, from a strength or a tolerance standpoint, then we can start picking and choosing what we're giving for them in the clinic and outside of the clinic a little bit more efficiently. And we know how much time should we allocate on something if we know what our ceiling for potential is. And when we hit that ceiling compared to normative data and population, maybe the person with scoliosis isn't going to have as much mobility or as much strength. But if we can recognize that early, then we know that we've maxed out the potential with that activity, and we can start allocating efforts somewhere else with that. So I think a lot of this just comes down to being mindful of what we're doing with them. One thing that we have not touched on with regards to the actual specific exercise interventions is the appreciation that what we should be doing with them should be asymmetrical in nature. If we're trying to put them into a lot of bilateral, symmetrical based tasks, but they have a foundation that is not symmetrical, we may be putting them in a position where they're less likely to succeed. So with activities, whether it's lower body, whether it's upper body, pushing, pulling, squatting, hinging, carrying, lifting tasks, be mindful that if we have a left and a right side of our body that does not have a similar starting point, if we have a midline that may not be so center midline, then we need to have that be reflective in our exercises as well. And just be mindful that qualitatively, we may be executing these exercises a little bit differently. So if you work with patients with scoliosis, hopefully this may not answer all of your questions, but hopefully it stimulates some questions that you can ask yourself so that when you go into these situations, you at least have a framework and a mindset to go into it with, and then you can fill in the gaps with whatever your specific individual is, what their presentation is, what their goals are, and the resources that you have at play to utilize.